Up next is Symposium 5, which is on conundrums in rheumatology. I cordially invite Dr. Gunendrika Kasturiratne, Consultant Rheumatologist, National Hospital of Sri Lanka, and Dr. Nandana Dikmadugoda, Consultant Physician, National Hospital of Sri Lanka, to chair the symposium.
Good evening. Welcome to the Symposium 5 of the 57th anniversary academic sessions of Ceylon College of Physicians. We are starting the Symposium 5. The academic committee has named it as Conundrums in Rheumatology. I am sure when we finish this, you will be facing is a simplified matter because we have 3 eminent speakers. Let me invite our first speaker. He's Professor José Delgado Alves from Portugal. He's a professor of medicine in Nova Medical School, Lisbon, Portugal. He has delivered more than 500 international lectures on rheumatology and immunology. Over to you, Prof. Delgado.
Right. Okay, thank you very much. Good afternoon, dear colleagues. It's wonderful to be here in this magnificent country. Thank you so much for inviting me, and thank you so much for the opportunity to be here. And Chiranti, I don't know whether she's in the room or not. She's been a fantastic colleague, and she was responsible for me being here, so I thank her and to all the organization. So, if I may carry on, these are my disclosures, which have nothing to do with this presentation. So I was supposed to say Hayubowan to all of you, and that's, I hope I said it right. So in the next 20 minutes or so, I'm gonna try and do a bird's eye view over a concept that we believe in and we are trying to do with our patients in my unit in Portugal. And basically that has to do with precision medicine and the way it evolved from what I believe is another concept of doing, which is evidence-based medicine. It does have its flaws. So, first of all, systemic lupus is a complex, multifactorial disease. It's not just one single disease. And we now know that there are molecular and clinical patterns in SLE that make it a completely different disease. We always say that when we are in our office, we will see 10 patients with lupus, and all of them are different. And we never thought, if they're all different, maybe they have different diseases. We just decide to call it lupus, but maybe it has different mechanisms, and we should think about that. Now, the question is, how can we choose the right drug for the right patient? And I know that patients who have mild disease, what I would say a normal current form of disease, probably we should treat them in a guideline principle because it's cheaper, it's easier, and it's more homogeneous. But we have so many patients, and my center is a referral center in Portugal and actually in Europe. So we get all sorts of funny patients, strange patients, patients that get symptoms that, you know, it doesn't make sense, patients that respond to therapy in a way that we were not expecting. And that is why all the consultants and all the registrars in my unit have to work in my basic immunology research lab. And so when we have these patients, these funny patients, these strange patients, we always get whatever we can from them and take it to the lab and try to understand what mechanisms are behind that particular patient, and then try to target the right drug for them. So that is the issue here. Should we move on to precision medicine rather than evidence-based? And I will dwell a bit about that later. And then targeting the right pathway. I'll give you some examples of my unit and how we work, not just in lupus, but in systemic autoimmune diseases. And then hopefully I'll come to the final comments. So systemic lupus is a complex, multifactorial disease. Many years ago, and I apologize for these cartoons, which are a bit full, but we would start on the left-hand side corner, and we used to say that lupus was a waste disposal disease. So our body could not dispose of the apoptotic bodies. And those were strange things floating around, activating the immune system. Initially activating B cells and then activating T cells subsequently, bringing up complement, and the whole thing would get sideways. And that was sort of like a story that starts in the beginning in the left and goes all the way. And all parts of the immune system would come activated in a sequence. We know better than that now. We know that things don't always start the same way. Things can start in many different ways. In fact, we know that several factors can influence the way things start. What kind of activation will prime the immune system for the rest of the things? We have patients where we realize that the first trigger was actually B cell activation against, say, C1q, antibodies against C1q. Nobody used to test them 20 years ago. Now we test them routinely in our unit. Some people have to do with the misrecognition of toll-like receptors. Some have to do with the fact that complement is activated and we have lupus that looks like inflammatory syndromes. Patients that come with high fever and we look, where's the infection? Where's the infection? And we keep chasing the infection. And eventually, if it gets serious, we keep giving antibiotics. Well, antibiotics don't treat the fever. Paracetamol does. So not everything that has a fever is an infection, and we have to be aware of that. So now we have a different approach, and we have to think that many of these patients have a specific activation. Does the disease in this particular patient started with interferon activity? Well, we have an anti-interferon receptor now that we can use specifically. Does it start with the production of an antibody? Then we have a drug that will attack the B cells directly. And is that antibody produced by a CD20 B cell? Well, in that case, we have rituximab. But if it's not, then we have eprotuzumab for the long-lived. So we have more target drugs for specific diseases. Now, is this more expensive? Yes, it is. But we don't use this method in all the patients. We use it when we can't figure out what's going on. And the fact is, this might be expensive to actually take the blood or the serum or the spinal fluid or whatever we need to the lab and look at the cytokines, look at the cells, see which ones are activated. But how much does it cost to give the wrong treatment? How much does it cost to keep pursuing something which is just not there? So studies have been made to look at molecular and clinical patterns in SLE. And this was a study with quite a few patients, and they looked at both clinically but mostly molecular patterns. And they found 7 clusters in SLE patients. And those 7 clusters, and you can see here, they have to do with different parts of the cell and the immunology response. They go from interferon-based to cell type, to platelets, to antibody production. And interestingly enough, what was found was that these clinical clusters and these molecular clusters varied according to the manifestations of the patients. So if the patients had more inflammation, more interferon activation, they would have more cluster 1, more cluster 4, and that means that they would have eventually more renal, more pulmonary, more serology in terms of lab. If they had other types of cells, other clinical features would come up. Renal activity, for instance, that was more frequent when patients had cluster 4 active. And it was rare when they had clusters 2, 5, and 7. So you see, looking at different molecules, we can see that it turns out that lupus actually is not a single disease, and we should stop calling it a disease. We should call it a syndrome, because it's lots of diseases in it, and we just need to understand them, looking at the basic immunology. Now, this is gone from Marta Alarcón, and it's a multinational group. We've participated in Portugal as well, and we tried to make it a bit more simple. And this is a study that was made in lupus and in Sjogren's syndrome. And what we found were 4 different clusters. It was either inflammatory, or lymphoid, or interferon-based, or, well, there were some that were undetermined because it was a bit of a mess. We still can't find which thing triggers them. But the fact is, when we split our lupus patients into these clusters according to their activity and according to the way they present, if they have more CRP or more amyloid A or more ferritin, if they have more fever or more joint pain, if they have renal problems, when we start splitting them, we can choose wisely, or more wisely at least, the drugs that we want to use. So the question is, can we choose the right drug, the best drug for the right patient? Well, I would say that immunosuppressors, they are not all the same, even though they do look like it, but they're definitely not the same. And we have to be aware of that. So, are we treating a patient or are we treating a disease? And when we look at treat to target, more of a precise medicine, our focus is actually the patient and improvement outcomes. It increases cost, but at the end, you have an incremental cost effectiveness. And interestingly enough, the level of evidence is always moderate to high because we know on that patient what is activated. Now, when we look at evidence-based medicine and clinical trials, I'm the chairman of the European Committee for Independent Clinical Trials. So I like clinical trials, but we have to know what kind of answers they give us. We're just talking about pregnancy and how pregnant women don't go into trials. There's several reasons for that. But the question is, if they don't go into trials, how can we be sure that those drugs can be used in all the patients? So we have to be aware that clinical trials they were not designed to define treatments. I am sorry, but they were not. Clinical trials were designed to approve drugs. Then using those drugs to treat the patients. That's why we went to medical school for. I myself and the people that work with me, they choose the drugs. And they have to respond. They have to answer to me why they chose that particular drug. I don't accept it's because it was in the guidelines. I don't accept that. If it's in the guidelines, great. But that is not necessarily the reason to treat it. So it reduces costs. We're actually treating to budget. Anyway, I'll give you an example of 2 drugs. Codeine, which is used in many countries as an analgesic because it transforms itself into an opioid. Morphine is a prodrug. And clopidogrel, which is widely used all over the world. And guess what? When you look at the RCM of clopidogrel, well, you're using it to block platelet aggregation, to avoid thrombosis. But the fact is, you do not have a clue if the patient you're giving that drug is a fast metabolizer, if he's a slow metabolizer, if he doesn't metabolize clopidogrel at all. And if he doesn't, you're giving clopidogrel and you feel safe, the patient feels safe, but actually what he's taking is a placebo because he doesn't have the right enzyme to deal with it. So we have to be aware of those things. So what about precision medicine versus evidence-based medicine? The question is, what is exactly precision medicine? And one thing that we should know is exactly what we're talking about. And I always like to define clearly what I'm talking about. So Ferrari, we all know the car brand, it's an Italian car brand with great power, developed for competition, recognized by its red color, and it has a white horse as a symbol. So there's no doubt what Ferrari is. Everybody knows it. So that is the point. We really need to know what we're talking about. So precision medicine, it started in the 90s, beginning of the 21st century, and the whole thing actually had to do with the 4 Ps. Participatory, personalized, predictive, and preventive medicine. And this is all very nice. But actually it came out of the generation genome, the genome bang. So we all thought, little we knew, we were so naive, that once we find the genome, that's it. We're set for life and we will know everything about the diseases. What we forgot about genetics is that more than 80% of our genes are actually regulatory rather than other things. And actually epigenetics is much more important in terms of phenotypes. But anyway, so it became mostly technologic with the development of computers and big data treatment. But it went from genetics into cell membrane receptors and other proteins. Look at what's happening in oncology now. I talk as an immunologist. I do immuno-oncology as well. And I talk to my fellow colleagues, our fellow colleagues, oncologists. They don't say, oh, that patient has a breast cancer. They don't say that anymore. They say, oh, that patient has a breast cancer, break 1, type 2, receptor AF32, whatever. And there's a drug for that. You know, nobody calls that anymore because receptors have now shown us what the real targets can be in terms of treatment. So during the Barack Obama reign, the White House in the United States presented this precision medicine initiative. This was in 2015. And the question was, most medical treatments are designed for the average patient, not for the patient in front of us, for the average. And in fact, one size does not fit all. I don't know the first years here in school in Sri Lanka, what they say, but in Portugal, we always say to our first year students, each patient is different and you should treat the patient, not the disease. And then we go for clinical trial based where one size fits all. What's wrong with this picture? So there you are. So the idea was to get into the genes, get to the environment, get to the lifestyles, and see how these could be put together in order to understand what's going on with that specific patient. But that was a problem. Because when we look at the genes, we are very far from reality. Because one thing is the genome. The other thing is all the transformations that happen from a gene to a clinical phenotype. And that is hugely different. In fact, we have all sorts of omes, including the epigenome, the way in epigenetics things are transformed in the genes. So we need to understand that there's more to the patient than their genetic material. That's just the starting point. How he's going to finish, it's up to the rest of his life. And of course, there's big data analytics to try and organize this, and I'll show you an example in a minute. But this pretends to integrate the information of a specific disease, of a specific patient. So precision medicine can have actually 2 phases. One is the analysis of big data to try to understand what patient has what and how we can trigger that. The other is to get one single patient and see what's going wrong in that one and try to address that. This is a study that we did looking at the lipidome. So this is an example of big data. And we looked at atherosclerosis with 5 groups of cardiovascular disease and ischemic strokes and systemic lupus. And we tried to localize evidence of stress and cell death and how that would change with the lipids. Now, we did top-down shotgun mass spectrometry. I'm a bit late, I'm going to try and rush up. And we looked at 596 lipids in the total cohort. And we tried to classify them. And just to cut a very long story short, you can see, well, it's difficult for me to show, but if you look at the left-hand picture, the second column from your right, from the middle, you see lupus versus controls, and you see that the reds and the greens are different. And that means different genes were activated. In fact, what we found is that, and if you look at the top thing, you'll see where the pink is. That is the lupus patients. And they have atherosclerosis that looked like normal atherosclerosis, But it's completely different in the lipid content of patients that had just atherosclerosis. And when we try to look at this, we can clearly define what these patients, what kind of disease these patients have. Even ischemic stroke, patients that have atherosclerosis because of ischemic stroke had a completely different profile of antibodies. So targeting the right way, this is just some examples. 41-year-old Caucasian woman with lots of granulomas, so it was erythematosus. And then you had bronchi thickening, interstitial pattern, ACE elevated. It did look like sarcoidosis. Then she got low back pain in an inflammatory kind, and she actually had sacroiliitis. So it looked like spondyloarthritis. Then she had septal fibrosis when she started feeling more tired. Again, it could be from both. And then she started with abdominal complaints, and she had an undefined inflammatory bowel disease. And all of a sudden we thought, okay, this is too much. You know, either she's really, really unlucky, or we're missing the point here. And so we started thinking in a different way. So erythematosus, that's T cell activity. ACE inhibitor sarcoidosis, T cell activity. Spondyloarthritis, Th1, Th17, TNF on top. T cell activity on the heart, and certainly it was a TNF or an anti-TNF option for the inflammatory bowel disease. So we started her on anti-TNF. Should have worked. Guess what? It didn't. Ooh, sorry, I'll try and run faster. It didn't. So we thought, could this be a TRAPS-like syndrome? Because it looked so much like a TNF. What's a TRAPS-like syndrome? Well, I'm sorry, this line is in Portuguese because we've copied it from the result. What happens is when we get the receptor of TNF, there are variants, genetic variants, where the receptor auto-activates itself. So blocking TNF is no good because the receptor is activating itself. And that was it. So she had all sorts of TNF-like diseases. She just didn't respond to anti-TNF. So we did the stupid decision, which is treat her with an anti-IL-6, block inflammation, but in the next column. Guess what? She got better. She got well. So we really need to look at this other example, 59-year-old woman. SLE diagnosed in 2002, treated with 4 different immunosuppressants, plus steroids, plus hydroxychloroquine. None worked. That's a very, very strong wake-up call. IBD again suspected in 2022, but it was undifferentiated. And then she started on pyoderma gangrenosum. And we didn't know whether it was metastatic crown or what was it. We thought about treating her with anti-TNF, but she had a past of tuberculosis, and that got us really worried. I know you dominate and control tuberculosis. We're a bit different. Tuberculosis now is a more rare disease outside of the AIDS context. So we were wondering how we were going to treat this patient. And then we looked better at pyoderma gangrenosum, what was going on in the skin. And it just happens that the innate immune system in the skin answers via interferon. So we thought, what about we look at this lady and see what's going on in her skin? And when we looked at both her dendritic cells and her cultured skin, they expressed large amounts of interferon gamma. So we did anifrolumab, and she got all right. We treat her with an anti-interferon receptor, very specific after we got these results. Now, this is our last example, or my last example, a 29-year-old, again with clear lupus, started on everything under the sun, and again, nothing worked. Again, a very big red flag. Nothing's working. So we decided to look at her kidney and see why it was not responding to rituximab, to belimumab, to cyclophosphamide. And when we did IL-17 staining, it was there and it was quite obvious. So this kidney nephritis was being driven by IL-17. And we know this is not the only patient. About 10% of these patients in lupus nephritis are driven by IL-17. So we started her on secukinumab, an anti-IL-17 drug, which is not approved for lupus, but it worked perfectly, but it was approved for this particular lady, not for generalized lupus. And she's now in remission just with secukinumab and a very low dose of steroids, which we are tapering down. So you see, there is an impact on clinical medicine, and we need to change that. So what should we do with physicians? Better training in basic sciences, which was actually the genesis of internal medicine. Research experience, any type of research. Clinicians have to do research, any type. Clinical research, epidemiology, because it will help them to think and to ask the right questions. Then what should we do with the units? Promotion of training and practice in basic sciences and true collaboration with research institutes. All my registrars have to go through a basic research process during their training. And what about the disease? Well, if it's rare or complex, then we should look from the physiopathology point of view. Of course, the initial approach should be careful, should be homogeneous. We're not treating the first patient that comes to us with very strange drugs. But if the things are not going right, well, we should not wait for too long. So how do we decide about precision medicine? We strongly believe about precision medicine even when we are training our students. That's why I'll give you an example of how precision medicine can be helpful in career choice. So you have a medical student. First question is he crazy or is he sane? Well, if he's crazy, what is his attention span? Can he actually focus or is all over the place? Well, it's simple. Is it significant attention span? Does he actually focus on what he's doing, or he just jumps around and doesn't think properly? Well, if it's significant, he should go to psychiatry. And if he can't fix something for more than 5 minutes, then emergency medicine is fine. What about if he's sane? Well, is he hardworking? Well, he's very hardworking, or not so much, sorry. If he's very hardworking, the question is, what is his attitude? Is he nice? Doesn't matter. Or is he mean? Well, if he's nice, does he hate adults or does he hate children? If he hates adults, pediatrics. If he hates children, well, internal medicine. What about if it doesn't matter whether he's nice or not? Well, the question is the patient asleep or is the patient dead? If it's asleep, anesthesia. If it's dead, pathology. Well, it's pretty obvious. Now, what about if he's mean? Well, there's only one thing he can go to, and that's surgery. Now, if it doesn't matter whether he's hardworking or not, is he afraid of the light or is he afraid of the dark? If he's afraid of the light, radiology. If he's afraid of the dark, you have to think big or think small. If you think big, dermatology. If you think small, ophthalmology. So you can see precision medicine gives it all. So just to add up, autoimmune diseases in general, and particularly lupus, are very heterogeneous. And it has to do with their etiopathogenesis and dominant pathways. And they change, not only in the patient, but also they can be drug dependent, even time dependent. Clinical trials reflect average responses. They're limited, and they are in carefully chosen populations, not in everyone. And a general approach can and should be made for patients with mild or typical diseases. But a specific, precise approach should be pursued when patients are very young, the clinical phenotype is unusual, or there is an unexpected failure to treatment. This is my team, and it's thanks to them that are working in Portugal that I'm here spending my time with you. And thank you all for listening. Thank you very much.
Thank you very much for that excellent presentation, Professor Alves. I would like to invite my co-chair, Dr. Nandana, to present the token and the certificate of appreciation to Professor Alves. Professor Alves, can you please accept our token and the certificate of appreciation? Yes, now for the second talk, I would like to invite our second speaker, Professor Inoshi Atukorala. She is a senior lecturer in medicine and specialist in rheumatology and rehabilitation, Faculty of Medicine, University of Colombo, to talk on challenges in management of knee and hip osteoarthritis. Over to you, Inoshi.
Good afternoon. I'm privileged to be here and talk on the challenges in development and adherence to lower limb osteoarthritis guidelines, and I thank the Ceylon College of Physicians for inviting me to speak. I have unfortunately no disclosures. This is the outline of my talk. I will begin by explaining that we are not very good at implementing osteoarthritis guidelines and recommendations. And I will discuss some of the problems with guidelines and recommendations and think whether there's a problem with the patients or with the healthcare professionals, or probably both, while I present my conclusions. So we really need to pay attention to guidelines and recommendations in osteoarthritis. And it is because they are very helpful for clinical treatment, and they also give us some evidence-based guides on management. But less than 40% of people get guideline recommended care. And shockingly, up to 40%, and this is not only in our country, are referred to surgery without first-line care. We are spoiled for choice in terms of guidelines, and all of these focus on a core of physical activity, exercise, education, and weight management. And there are multiple other things which are appropriate for different patients. But guideline uptake is suboptimal. And there are many reasons. If you look at the guidelines and recommendations for osteoarthritis, they are not very actionable, and we'll talk about this. And some of them are confusing. One says one, the other says another. And also, you get the feeling that they are not perhaps developed as rigorously as they should be. So, there were systematic reviews done to select the most rigorously developed guidelines so that we have clear and simple guidance on what we can do in lower limb osteoarthritis. And they have used the agree-to quality assessment domains, and you may be familiar with this. So, due to time constraints, I will focus on what is the core program: physical activity and exercise, education, and weight management. The core recommendation in osteoarthritis uniformly, all guidelines recommend exercise, education, and weight loss for hip and knee osteoarthritis. And there is the three main cause strategies. I will take you through them, and then I will also explain that there are some guideline gaps or recommendation gaps, and then try to fill in these gaps using some evidence-based suggestions. So physical activity and therapeutic exercise is very important. This is from Sri Lanka, I'm happy to say. And increasing general physical activity, aerobic exercise, neuromuscular and strength training is the way forward. In the long term, physical activity improves pain and quality of life. But in the short term, it can cause pain, and it is challenging for our patients. So all patients with osteoarthritis should be active, and this is difficult. And it should be very patient dependent, and we've been through an excellent talk on personalized medicine, and individual patient should receive physical activity guidelines dependent on their osteoarthritis, their physical function, as well as preference and facilities. Each exercise should be progressively loaded so that the patient doesn't get fed up. But unfortunately, again, there is no guidance, if you go through these guidelines, on what to do whom to exercise, or there's some confusion. So what are the exercises? For knee osteoarthritis, mind-body exercises, Tai Chi and yoga. And yoga is very much acceptable in our climate, in our patients. Stationary cycling, proprioceptive training, weight and non-weight bearing exercises, neuromuscular and strength training are recommended. And we'll recommend walking, cycling, swimming, which will also improve our cardiorespiratory fitness. For hip, there are really no guideline recommended exercises, but there are some systematic reviews which recommend strength training. So how much? Again, no real recommendation as how much we should do for our patients with osteoarthritis, but the WHO guidelines on physical activity combined with strengthening exercises are what we generally advocate. But our patients are heavy, they have bad joints, they have multiple comorbidities, they struggle to move. So even if there are studies in osteoarthritis which show that at least 45 minutes per week, and this I think even the most sedentary of us can manage, and 6,000 to 10,000 steps per day might even be good as a starting point. So I use the lower bar because these patients need to be motivated and encouraged, not overwhelmed with impossible targets. There is a role for strengthening activities, and our physios are so integral for osteoarthritis management. They can develop personalized plans, educate patients, and also set goals and focus on adherence. There is also neuromuscular training and lower extremity and core strengthening, attention to patient compliance, and balance training, and also plyometric jump training are recommended. So I think some of you will say that I'm crazy. How can these old people jump up? But there are also elderly, age-adapted plyometric exercise programs which are actually possible even with our patients. The main component of the core program is patient-centered health education based on a biopsychosocial approach. We must assess every patient's physical and psychological status, activities of daily living, social participation, work and recreation, as well as their social determinants and factors, environmental factors. And we must develop programs which are guided by the patient's symptoms and physical function, while providing the patient appropriate information considering their beliefs and preferences. But one thing which is very important is self-management. Unfortunately, most guidelines don't provide resources, and we need to understand that we are going on a long journey with these patients, and we have to revise what we do with them and also provide them social determinant support at different care points. A heavy, overloaded, damaged vehicle is unlikely to go far. I think only in certain continents are we this optimistic. So the third component of the core program is weight loss. The minimum weight loss, there are diverse recommendations, and our main body, the Osteoarthritis Research Society, recommends 5%. The Royal College of General Practitioners, Australasian College recommends 7.5%. These are tough targets. Anyone over 50 will tell you this is a tough target. And again, there are no exact strategies, no exact BMI at which to intervene, nor much guidance about weight maintenance, which is very important. The main trial for osteoarthritis is the IDEA trial in Wake Forest, and they have shown that the exercise group might lose up to about 2%, the diet-only group about 10%, and the combined group about 11 to 4%. This is clinical trial, and a very, very restrictive diet if you are happy with 2 meal replacements and a 500 kilocalorie diet. Not easy. This is our research from an Australian community-based study. Again, this is in the community, so we showed that at least even 2.5% weight loss is associated with a minimum clinically significant improvement in physical symptoms, functionality, and this is something most people can manage. The optional treatment strategies are really second-line care, but our patients need pain relief and they need help to move and exercise. So there are two agents which we use which are not great in this cohort of patients: non-steroidal anti-inflammatory drugs and topicals. Whenever possible, use topicals. But if you can't, you might have, depending on contraindications, to the non-steroidals. Paracetamol doesn't have a really good effect in osteoarthritis, though people have touted it as such. And we are increasingly convinced of side effects in these patient populations. So there is kind of controversy as to whether we should use it. There is a place for steroid injections to joints, short term, but there is very little evidence for hyaluronic acid and platelet-rich plasma, which is aggressively promoted in our country and elsewhere. And so I think we really need to think, if we are giving corticosteroids, it will be shorter, only for a little time until we correct or improve the patient. The adjunct therapies, so cognitive behavioral therapy works, and I will talk why it works as we go on. And walking aids are also recommended. These don't have evidence, but they help our patients and they are relatively safe, so that's okay. Nutraceuticals, $1 billion industry. It's all red, like one political rally. So nothing really to promote that these things work. Again, all our patients request this most of the time. So this is the summary of lower limb osteoarthritis guidelines. But most guidelines do lack details on how to implement this. So this is going to be a problem. And before we blame our patients, we must think, do our patients have problems and how can we circumvent them? The guideline recommendations need significant and sustained behavioral modifications. They are multifaceted and multidimensional, and we can't measure adherence because it is very, very complex. And the data for diet are really quite scary. We are asking 10% weight loss, and only 20% of overweight, not obese, can maintain weight loss of that amount after 1 year. Even more upsetting is that 50% of the weight loss that they have achieved is lost in 2 years, and 80% in 5 years. So it's really, really scary. Even in the clinical trial setting, after they left the clinical trial, they did gain weight. So we are thinking, are the next line of drugs, do we lean for Ozempic and its cousins? And they may be game changers, but there is really, we are going to have the same problem of maintenance of weight. What about exercise? Even in the best economies, supervised exercise programs with physios reaching out to you all the time, the exercise adherence is very low. It's the same for physiotherapy. So how do our patients in Sri Lanka fare? And this is a research project which we have just completed. I'm just bringing you some things which might be useful for your patients. 400 mainly women who are older with predominantly knee osteoarthritis who are heavy. They were quite happy with the health education given, though they would have liked longer consultations, and anyone who knows our clinics will agree with that. So why didn't they do physical activity? The results, 60% were advised on health education. We don't have health education professionals regularly in our clinics, but we have physiotherapy, and most of them had been referred for physio, but they cited lack of motivation, lack of time, and pain during exercise as the reasons they did not adhere. And pain during exercise, I'm not presenting all our findings here, is mainly in older people. So that was one of the things that we should consider. When it came to the healthy diet, lots of people had financial difficulties in actually using the healthy diet, and we need to be mindful of this for our patients. Of course, they found the healthy diet difficult. You know, the meal that you had just now, other people have lesser levels. It's not easy. They didn't have idea on how to manage food within their budget. They didn't have time, so they reached out to quick fix fast foods, and they did also lack social support. So all these things were really problems with adherence to the diet. So we come back to the combi model where if we need to change behaviors, the patient needs to be capable of doing it in addition, and also to have the opportunity, in addition to being motivated to do it. So the bottom line is the individual patient needs to be empowered, and the plan we provide must be specific to him or her. So we need exercise prescriptions to improve physical activity. And this is based on the joints affected, the mobility, the comorbidities, goals, and facilities. And you choose the exercise type according to patient preference. Our patients like to walk, but they are not very big fans of strength trainings, most of them, and that is very important for them. We generally like to encourage them to move more. Ideally, we should have supervised sessions and reminders, and they are doing web-based reminders and SMS-based reminders. This is challenging. Our patients change their SIMs all the time. It's very, very difficult to follow them up longitudinally, but we can develop some mechanisms, and they need peer support. So this is the way that we can potentially improve physical activity. And then also healthy diet. Almost all of our patients had been referred to dietitians, but they need all and every single healthcare provider to reinforce this message. And we need them to have also coping strategies, and also even pain coping strategies, because lots of patients actually overeat when they are in pain and sedentary and unable to move. So cognitive behavioral therapy is also helpful. But we also need to think inwards. Could it be a problem with healthcare professionals? And we are increasingly encouraged to use patient-centric conversations during consultations to improve adherence. And this is the kind of model where you ask the patient and you identify triggers and use that to suggest the solution. But patients also, that's motivational interviewing, which is an art which needs to be taught, I think. And the patient also needs explanations and educational resources so that they will overcome the misconceptions and benefits of core interventions, because lots of people are in a state of apathy, and some people think their joints are damaged, so moving more will cause more damage. So that is very important, and regular supervision is also important. There is this really nice study about perceptions of healthcare workers and what they think about osteoarthritis. And some of them think osteoarthritis is not that serious. Actually, there's a white paper showing that it is serious. And when you trivialize the problem, either to the patient verbally or you think of it, it's hard to sell the subject. The guidelines, as I mentioned earlier, don't have clear instructions. Perhaps we need guidebooks rather than recommendations and guidelines, and I think that would work well. And also we have the dissonant patient expectations. Some people think this is rheumatoid arthritis, they want DMARDs. Some people want glucosamines, curcumin, and turmeric. So that is also important. But also, a lot of the healthcare professionals also have their own beliefs. Diet does not work, diet is difficult, exercise is difficult. So all these things are working in the back of your mind, and you can't sell a treatment which you really don't believe in. So SLE is very exciting. And when when you're young, the young people will think of it like, they might think of Selena Gomez, who suffers from the disease. So it's interesting and everybody wants to learn about it. But when it's osteoarthritis, it's something older, more serious, more important and grave, and perhaps not very interesting to really read about it. But 1 in 8 people will develop osteoarthritis, and if you are over 70, 1 in 3 of you will get it. So it is a very important topic you need to know. So either you, your relatives, or and most certainly your patients will get it. So you need to have good strategies. In conclusion, there are multiple guidelines and recommendations, and they all advocate the use of co-treatment programs in lower limb osteoarthritis. There is difficulty in implementing these recommendations because there is lack of clarity in the guidelines, and there are barriers which impact individual patient adherence, and there are clinician-related factors. The ideal osteoarthritis care in resource-poor settings is difficult and costly, but not impossible. And we need to properly assess our ground situation so that we can improve osteoarthritis care and give some relief to our patients who are really struggling with this disease. So there are many people I need to thank, and some of them are listed here. And I would be happy to take any questions. Thank you.
On behalf of Ceylon College of Physicians, I must thank Prof. Inoshi for her very interesting and very elucidative lecture. And I request my co-chair, Dr. Gunendrika, to hand over the token of appreciation. We are running behind the time, so yeah. So the question and answers, maybe we have to delay. Thank you, Gunendrika. Today, our last lecture, interpreting autoantibody test results. I think the speaker, we don't need introduction, very eminent speaker and teacher, Professor Suranjith Seneviratne is the professor and consultant in clinical immunology and allergy, Royal Free London NHS Foundation Trust. Over to you, Prof. Suranjith.
Thank you. Thank you very much for the invitation and to speak at this wonderful forum and college sessions. Thank you for the introduction. So I don't have any financial conflicts of interest. Only conflicts I have is that I'm the batchmate of two presidents, the current president of the CCP, Upul, and the past president, Duminder, but no other conflicts of interest. So I was trying to get, and I know you all are in a hurry to get back home and to vote tomorrow, and I'll try to make this short. I was in a bit of a hurry to, I was trying to get out of this talk because as Professor Alves has spoken, 25 years ago when I left Sri Lanka, exactly 25 years ago with zero knowledge in immunology to go to the University of Oxford, I mean, people would not talk in a rheumatology forum so much of immunology. And now, it's genetics and immunology. It's really, really a lot of immunology is spoken and about precision medicine, etc. So I was trying to get away from this because autoantibody, it's boring. It's sort of, we want to talk about future medicine, etc. That's what immunologists do. But Uful was insistent that I spoke to you because there's lots of confusion in Sri Lanka and just to get all on the board. So I'll be, some of the aspects will be very basic, and excuse me for that, but I just want to bring it, try to wrap it up for even the juniors, the registrars who are there. So the summary would be the basic spectrum of autoantibodies, healthy, and when I talk about autoantibodies, I won't be talking about adrenal, thyroid, etc. There are those autoantibodies, but I'll try to concentrate on the rheumatology, where otherwise it's too wide, and I'll be speaking till tomorrow or till the election time. So if you look at the immune system, you have viruses, bacteria, fungi come in, trying to attack our body. Innate adaptive immune system described beautifully, antibodies, white cells, lymphocyte, complement. This protects us from getting infections and keeps us healthy. Sometimes the immune system misbehaves, starts attacking our own body, autoimmunity, allergy in a dysregulated way. We react to things in the environment. Sometimes they can't get rid of the cancer cells and they develop cancer. So this is dysregulated immune system, and cytokines play such a vital role in talking. They are the language of the immune system, talking between cells, etc., and giving the signals to the immune cells to do their function. So we'll talk about autoimmunity. That is where the immune system starts attacking our own body and producing these proteins and cells. And I will concentrate mainly on the antibody part of it rather than the cellular part of it, but that's what we really detect in our laboratory tests. So there are over 100 autoimmune diseases, and as you say, I will concentrate on the rheumatological aspect rather than going on to the other aspects like adrenal, etc., which we know. multifactorial, environmental, genetic, etc., as was described beautifully, and those getting together to produce the range of autoimmune diseases, which are more than 100. So there is a spectrum of autoantibodies in connective tissue disease. This is sort of just a snapshot of the spectrum. In rheumatoid arthritis, SLE, Sjogren's, myositis, and systemic sclerosis, there's a whole range, and you can see the overlap. There are some antibodies that are found in several countries. That's where this mixed picture comes in. And knowing this pattern would help you, direct you. And remember, this is not a gold standard. Certain things, I mean, it's not like a biopsy. You get the absolute. These are just aids. Your clinical findings are so important. You take your clinical findings, put in the results, and then take it together to the next stage in making your diagnostic, differential diagnostic. So if you look at the ANA, anti-nuclear antibody, you all know about it. This is a test that has been there for ages, and long ago there was this thing about a leaf cell phenomena where we looked under microscope and identified some cell called Elif. I don't think the current medical students have heard this aspect. Long ago, just near the end of the war. Then you have the anti-nuclear antibodies using immunofluorescence. Previously, they used rodent tissue, but then the HEP2 cell came in, and now we use the HEP2 cell as the cell that you would use to look at the immunofluorescence pattern in the anti-nuclear antibody. You have the ELISA test coming in and the multiplex bead assays or blots that are coming in, which are faster, but each of those have their pros and cons. I won't go into great technical details now, but I will give you a idea of what happens in London. So in London, what I want to bring in here is, in pathology, now I look after, so I'm a clinical immunologist who sees patients, but also overlook a lab. So in pathology, you should have some harmonization, because if every lab tries to do their own thing, the clinician gets confused. And that's the problem that I have when I come to Sri Lanka. If you send autoantibody tests, all the labs are doing so many different things that the clinician, when they get the result back, they do not know how to interpret those results. That's the issue. Now in London, we have 3 big centers. HSL, the biggest center in Europe or even in the world, because when you combine it with Sonic Health in Australia, it's a combined group. I'm in that group, heading immunology there. Then you have the West London, the St. Mary's and the Hammersmith group, and the St. Thomas's group and the St. George. So it is harmonized across the centers. And you don't have small labs just turning out reports, because that is very, very confusing to the clinician. So these are the different ways you can use to get your ANA pattern. So immunofluorescence, ELISA, and immunoblots that I use, or bead arrays. So ANA, 2 broad groups. Autoantibodies to DNA and histones. That is the actual complex, the DNA and the histones that it is, the DNA coils around. And that is dsDNA and antihistone antibodies. And then you have the extractable nuclear antigens, the common ones, Rho, La, Smith, RNP, SL70, Jo1, those 6. Don't try to remember everything there, because if you try to remember too many things, you'll forget everything. It's just those 6, if you remember. Then the more specialized people will remember the other ones. So you have the dsDNA histone, which is clinically okay, not so, but dsDNA is important. And then you have these ENA antibodies, the 6. And you have the pattern. Now the important thing is the ANA present or not? 4 basic patterns. If you try to have 50 different patterns, you're going to confuse the clinician, right? Because I see reports coming with all these different patterns. I don't know what those are till I refer a book, right? So homogeneous, speckled, peripheral, nuclear, and the centromere. Centromere is very easy to detect. You look at it on a microscope, stay in the cell, and you will identify the pattern. But the important thing to remember is you don't make diagnosis. You'll be sort of pushed towards a possible diagnosis, but you don't make a diagnosis on a pattern. You can't look at a pattern and say nucleolus, so therefore the diagnosis is this. You can't make it like that, because there are so many issues with reading patterns, etc., when it comes into the people who are reading it. So these are the sort of things that are described in the literature. If it's homogeneous, it may be a dsDNA or histone, and it is SLE, rheumatoid arthritis, but those are not clinically robust. You have to combine it with your clinical features. You can't just look at a pattern and say homogeneous, so therefore the person has SLE. That does not, because then you would not have other classification criteria, etc. And then you have the blots. This is the ENA blot. If the ANA is positive, we go ahead and do the ENA and the dsDNA. And the ENA blot, you can see a lot of those proteins that are there, or antibodies against the protein, but we just generally concentrate on the 6 important: Rho, La, Smith, RNP, etc., which I told you, the 6 Jo1 and the 6 autoantibodies that are important. Now, the importance of ANA. A negative ANA is more important than a positive ANA, because positive ANA can be present in so many non-specific things. So that is important, because if you have negative ANA and the clinical history is not suggestive of something that does need to follow up, that is the important part of it. And that's why when people, now our lab does hundreds of ANAs per day, the person reading the slide can be quite frustrated because all the tests seem to be negative. But that's an important finding, because that means you wouldn't follow that pathway unless which the clinician will decide. And again, important, don't be misled by these patterns, because you just can't make a clinical diagnosis which say homogeneous, etc. You cannot make it. And certain patterns can sort of not mimic, they can blur the other pattern by being at a higher concern, because you can have two patterns in the same patient. The sensitivity and specificity. I told you, depending on the disease, the sensitivity and the specificity varies, and you can see in the condition lupus, the specificity of is only 57%. So therefore, a negative test is far more important for a clinician rather than a positive test from a clinical perspective. Limitation of the ANA. The presence does not mandate that they have autoimmune disease. They just say that it has autoimmunity. Because many a patient comes to clinic and has referred, they've got the ANA report, they've gone on Google, Dr. Google has taught them that they have autoimmune disease, they have lupus, and they are really anxious. And then when you tell them, okay, you have this, we'll do the other 2 tests, etc., and reassure them, they absolutely, it's just a test. Just the ANA doesn't indicate that they have autoimmune disease. You have to fit it with the clinical picture. As I told you, the different patterns are important, because you must not get confused with the patterns alone. Now remember, healthy individuals can get these autoantibodies, and they can be a predictor of these conditions later on, as seen in people who were entering the armed forces. When they measured it and they followed them up over years, like what the Americans do, they found that there were different patterns that were, the different diseases that were developing at different stages. But you just observe those patients without worrying them too much. So these are the papers that came up showing that certain autoantibodies can develop into disease in a later stage, and rheumatoid arthritis is a good example to show that. These are the sort of autoantibodies present before clinical diagnosis of systemic sclerosis in certain groups of patients before and after, and the titer can rise. Now, when it comes to lupus, you have the classification criteria, lots of immunology in this classification criteria. You could see previously the previous criteria did not have, but many immunology tests come in, and that's where the immunology lab comes in quite critically in this in the clinician's profile. And the important thing to remember is that the immunology lab should be in close discussion with the dermatology, rheumatology, hematology team. You can't work in isolation. Because if you're working in isolation, how do you know? Now, our rheumatologist, Professor David Eisenberg, the big scleroderma unit in Rolfree and UCLH, are big centers, always in discussion. And they would indicate what comes out from the conferences, etc., so that we can develop these different tests, as I'll show you for scleroderma. dsDNA and Smith, those are the antibodies that are important in lupus patient, Smith especially, and dsDNA is the one that we would remember, use a criteria test, not an ELISA, because you can have a false positive. That's an important, it's a criteria test that will confirm. And then That is the test that we look for severity with C3 and C4. You don't have to repeat ANA every time the patient comes, but that is not a prognostic marker. Why the ANA is positive? Because if you have a Rho antibody, etc., it's so important in pregnancy. Then with regards to the heart effects, etc., crossing the placenta, lungs, again, some Rho antibody, and the renal exacerbation, anti-dsDNA, etc., there is some information that we can gain from that. Then when it comes to scleroderma, now this is one area that we really help, the immunology lab really helps the clinicians, especially with the big scleroderma unit at the free. That is because by subtyping these different antibodies, we do all these autoantibodies in a patient with scleroderma once it's positive, they can look for certain complications. Say if you see something like an anti-RNA polymerase 3, they would be really monitoring that patient for renal complication. If you look for anti-TH-TO antibody, they will be looking for pulmonary arterial hypertension, interstitial lung disease. So depending on the spectrum, we provide a service so that the clinician can make use of this and then follow up the patient appropriately. So this is the sort of spectrum in patients with scleroderma that we would use in our labs to screen the patient. Next, a big development that has come up is in myositis, because the myositis blocks are coming out at a rate and it is having clinical significance. Now, we all know about the anti-synthase antibody, the JO1, etc., because if you have a JO1, it's a real JO1, you have to be careful about lung effects, the effects on the lung, and monitor those patients very carefully. So this is the spectrum of autoantibodies that we measure in a patient with myositis. And we use a blot. And this has an important, because there's a special myositis, this has especially in the big center, this has special significance, because if you have MDA5 antibody, you would look for lung disease in that group of patients. JO1 antibody, there's some malignance associated, skin disease, etc. So that blot is useful. We have newer, it can guide us towards certain diagnosis, and there are new, this is the sort of a breakdown. If you have anti-synthase antibody, anti-MT5, you will think of the possibility of lung disease occurring in this patient, monitor the patient. Then if you have these antibodies, you'll think of the possibility of development of severe myopathy. And though that is the clinical information that an positive autoantibody test with the clinical finding would give in this group of patients. So this is the first sort of existing myositis blot. This is the newer blot that has come in, and we use this blot to be able to inform which the clinicians take and make use in their clinical diagnosis and their clinical decision making. Finally, I will go in, because I have just 4 minutes left, to talk to you about vasculitis in this perspective. ANCA-associated vasculitis. There are many vasculitis. Vasculitis means just inflammation of blood vessel. There is ANCA-associated vasculitis, and that is where you have antibodies against certain components that are found in granules of the neutrophil. That is inside the neutrophil, granules PR3, MPO, those granules, specific granules, and the eosinophil granules. And way back in 1982, these antibodies were detected against those proteins in the cytoplasm of neutrophils. Then they were found to be associated with GPA and EGPA, those days called Wegener's and Church-Strauss, but now the name has changed. There was a historical sort of development of these autoantibodies, and these are freely used in helping manage, the management of patients with ANCA-associated vasculitis. So different labs use either ELISA screen method or indirect immunofluorescence, depending on the size of the lab. In the UK, again, it's split halfway. We use indirect immunofluorescence, and if it's positive, we go for a MPO or PR3 ELISA. This is how we use the indirect immunofluorescence, ethanol fixed neutrophil, and look at the different patterns. And then, depending on the pattern, the proteins that are involved, the antibodies against these different proteins. But again, don't get too carried away. The important thing is PR3 and MPO. That is the important take-home message from there. These are the associations. Way back, they found this standardized study in GPA. PR3 was about 70 to 80%, and MPO about 10%. In eGPA, it was 30 and 30%, and MPA, it was 30 and 60%. So this is just a take-home sort of the rule of thumb that you'll have. That is PR3, you will talk in more of GPA, and if you are in MPO, you will talk in more of MPA. So those are the important things to remember. Important take-home messages from this is two major diagnostic pitfalls. Remember, in subacute bacterial endocarditis, you can have these ANCAs coming up, even PR3 or MPO, especially PR3, and patients taking cocaine, etc., can have this issue, and it's limited use in monitoring. Now you find the houseman come in and then requesting ANCA. Every month they are requesting ANCA when the person comes to clinical, and it's a waste of money, and we just would not allow that. Somebody in the lab will phone them and just give them blast. They would not be allowed that because it's a waste of money. You can use it for something else. So it's not used in monitoring, but the teeth of MPO, PR3, some of the clinicians use it, but at different intervals rather than just using ANCA as a sort of monitoring. Now, the classification criteria, 2017 and then later on. So there are two pathways that have been proposed. One is doing indirect immunofluorescence. The positive, you'd use MPO-PR3 ELISAs, or the other way, you screen with a MPO-PR3 and then ELISA, and then go into, some stop at that, but then others go in and confirm with the indirect immunofluorescence. So two different pathways. Our lab uses one. Several labs in the UK uses the different, but it is based on discussion with the clinician rather than the lab making their own decision. It's important the clinicians and the big vasculitis center in North London. So this was a important thing. ANCA testing should be performed in the correct clinical context. Don't do it on everyone who comes with a snake bite or something. It is in the important context, because otherwise it's a waste of money. Right? You should be suspecting ANCA-associated vasculitis if you're going to do that. If there is clinical support, then, so this is it. If there is a negative MPO-PR3 result, but the clinical suspicion is very high, use a different method we always have this in medicine. We don't have clear-cut cases. Use a different method to confirm. Importantly, this indicates that in certain diseases, ANCA testing is mandatory. Extreme mandate, but in other conditions like inflammatory bowel disease, etc., don't do ANCA testing because you're just wasting money. You get false positive, and then you'll be wondering what are you to do with this patient, where do you go from there, and that will complicate matters. So what I've done in this 20 or 25 minutes, spoke to you about the basics of autoantibodies in rheumatology, the spectrum of autoantibodies connected to disease. There's a whole range. Said that some healthy individuals can have it, but you have to monitor them in the appropriate context. Having an antibody does not mean that the person has autoimmune disease, because it has to be linked with a clinical feature, and you should request this if there is a clinical pretest probability of it being relevant clinically, because there's no purpose in otherwise doing it at all. But that's the importance of clinical diagnostics. You do it if there's a good pretest probability. Looked at SLE, systemic sclerosis, myositis, vasculitis. The big advances have been in systemic sclerosis and myositis. Thank you.
Okay. Thank you very much, Professor Seneviratne, for that very informative and excellent presentation. I would like to invite Dr. Dikmadugoda, my co-chair, to present the tokens of appreciation, a small token and a certificate of appreciation to Professor Seneviratne. And at the same time, I would like to invite all three eminent speakers on stage. We are going to have a very short Q&A session because we are running very much behind the time, expected time. Professor Inoshi, Atukorala, and Professor Alves. We would like to allow 2 questions from the speakers. Very sorry about the limitation. Questions? No questions. So,
Thank you, everyone. And my question is actually to José. It's, you spoke about patients that don't really fit in and who don't respond, and then develop all these strange combinations that are quite difficult for us to figure out. And you spoke about the importance of knowing basic sciences for us to pinpoint where the problem is. How do you, in a clinical setting, how do you generally go about it? I don't know whether it's that my basic sciences are really poor, but sometimes I find it very difficult to figure out what's going on. How do you, like, practical setting go about it?
Thank you very much for your question. In brief, this is not something that you do overnight. So the first thing that I would say is, when should you suspect that there's something funny? Most of the autoimmune diseases are not supposed to happen in children. When they happen in children, when you have there are some autoimmune diseases which are typical in children, Inoshi purpura, for instance. But when you get lupus, when you get severe psoriasis, when you get severe IBD in children, always suspect of an immunodeficiency. We've always talked that immunodeficiencies always bring infections. That's not true. Immunodeficiency means a dysfunctional immune system. Most of these patients actually have autoimmune features. And there's one thing which is even more interesting. Some of them have infections throughout their younger years, but when they get to adulthood, they stop having infections and the autoimmune diseases happens. And then later in life, cancer happens, usually lymphomas or leukemias. But the point is, if you get patients that have very serious conditions that are only supposed to happen in adults, say juvenile arthritis is supposed to happen in children, okay. But if you get those diseases that are more common in young adulthood, if they come up in children, that's a very red flag, very big red flag. The other thing is clinical settings which do not make sense. They're not common. Then you should be aware of that. And the third thing is you start treatment and there's no response. If there's no response, you're in the wrong track. Now, going back to this, why, and answering to your second question, this is a matter of being stubborn. I work in the national health system in Portugal. And when they asked me, they invited me to be the head of the department, and my department now is a referral center for lupus and anti-synthetase syndrome in Europe. And we get patients from most countries in Europe and Brazil and Africa. And they asked me, okay, what do you want to be head of department? And I said, two things. Time to be in the lab, in the university, with my team in the lab. Two, I choose the people that are going to work with me. Those were the only, I didn't ask for more money. I asked for these two things. And when I choose someone, I always ask, for me in a referral center, 30% of the work you do should be clinical. I'm talking about a referral center. I'm not talking about, 30% should be clinical. 30% should be training other people, training students, training registrars, training younger doctors. And 30% should be research. So for me, it's mandatory that all the doctors do research. We've started a program with our registrars. So our registrars, they do a first year of internal medicine, and their second year, they go straight to the lab to learn techniques. They don't have to do a full research program then, but they have to understand what you can get from an ELISA. When should you ask for it? How should you read it? And you should think in terms of statistics, and you think everyone can do research. The most important thing in research is ask the right question. That's the basic. Learn to ask the right question. Let me put it this way, just a good example of how I think, I'm going to be very quick, how I think research is very good to help doctors thinking. Many, many years ago, when TNF drugs came to Portugal, there was this center where the first patient that they decided to put on anti-TNF, they started it on anti-TNF. And the patient had a complication. Nobody wanted to do anti-TNFs anymore. Now, if you have done research, you know that complications is part of a treatment. You know there are chances. It's bad luck, it was the first, but statistically it would have happened. So you know what the right questions are and you know how you should do them. So thinking as a researcher helps you to think better as a clinician. That's my view. That's why I have a program and all the registrars have to go into a basic training in my lab. I'm fortunate because I have my lab and I have my PhD students and they work there. And all the consultants have to have at least one research project. Clinical, basic, translational, epidemiologic, whatever. At least one.
Thank you, Professor Alves. And I want to ask one question from Prof. Suranjith. Now, when we get the autoimmune diseases, initially we might not see all the clinical features. Maybe the other clinical features might develop later. So there's a practice of doing autoantibody panels, especially in the private sector. So what do you suggest?
Panels, okay. So this is the big problem with allergy and autoimmunity. And I get, now if I take allergy and then come to autoimmunity, now in the UK, through the NHS, if a clinician requests all these big allergy panels or the GP, they would be brought to task because it's a waste of money. It's absolute waste of money. I know in Sri Lanka, people spend 60,000, 70,000 and brings me these big allergy panels. And I ask them, why did you do that? Because it is so many false positives, things which are not found in Sri Lanka, etc. So again, always in diagnostic testing, you must have a pre-test probability. And then you do a test, and then you have a post-test probability. So if you go and do just widespread panels, you're going to have false positives. And then you're ending up with, what do I do with that? That causes more confusion because the patient wants to know why that is red or is positive. And then you can't explain about that. You know that antibodies can be present without you having disease. So always it is an important thing is, that's why Sri Lanka, one thing with our medical training is that we get a good clinical training. Listen to the patient, examine the patient, and then order your panel or whatever. Then it's relevant because then you're making a good decision based on the clinical feature and then make a post-test probability. So always in diagnostic, pre-test probability, order something relevant and then a post-test. Allergies, misuse, the panels are absolutely misused, right? And people are just ordering autoimmunity. Autoimmunity, we don't have those massive panels. We don't have those massive panels at the moment. But allergy, you have this massive panel. And just people are just ordering and we don't know what is happening with. I mean, I still have to request.
Can I just point out in 2 seconds? No, you finish.
Yeah, and I just, in addition, I fully agree with what Prof. Alves said. I mean, that research perspective also really adds into the clinical perspective, and that is a very good thing to have.
Just very quickly, in my hospital, it was proposed to have immunology panels. The clinical immunology unit is the only one that does not use panels. I forbid it. All the doctors that ask for tests, they have to justify individually. Justify not to me, but to themselves. They have to think, I want this, and I want this, and I want this. Because every time you ask for a test, in fact, what you're asking is you have a question. And you have to explain to the patient, as it was said before, if the test is negative, sometimes patients come to me and they ask for, the fifth opinion. And they say, oh, professor, you're my only hope. You're my last hope. I know then that it's not a serious disease, because if they got to me, it's not serious. And they show me all these tests. And I usually ask them, which ones are normal and which ones are not. Oh, that's the fact, they are all normal. Aha! Guess what? Immunology is now fashionable, and people ask for immunology tests. The single most common cause for a clinical call is ANA positive. For what? For being alive? Because if you're alive, you can be ANA positive, and that's it. That's the only cause. And it's a serious cause, because being alive, it's a serious business. So every time don't do fishing expeditions when you ask for tests. You know what you want, and you ask for the test. And when you do that, if it's negative, then you have your answer. And if it's positive, there you have your answer, because you know what the question was. That's very important. I fully agree with you. Very important.
So two immunologists speaking on the same line, right?
Okay, thank you. We are running behind time. We are winding up the Symposium 5. We will show our appreciation to our eminent speakers.